Hi there. Welcome. My name's Colleen Clennon. I'm the bicuspid aortic valve nurse over at Northwestern, not Lurie.
You can come join us.
I'd love to. And this is Elizabeth Capella. She's my counterpart over at Lurie. We would like to welcome you to our second annual event. Thank you guys all for coming. We hope you find this evening informative, educational, and we just have a couple housekeeping things to go over before we start the night. So I'm sure everybody noticed that there is food in this room out here. Please help yourself. Take seconds. We will have a break later in the evening so you can refresh your plates. Bathrooms are located out in the hallway where the registration table was. After all of the speakers are done, we're going to be doing a question and answer panel, and how we're going to do that is we handed you some index cards as you walked in. If you have questions that come up throughout the night, or if you just have questions that are on your mind, write them down on those cards. Liz and I will be collecting them, and then we'll make sure that the questions that come up over and over again are all answered, and as many others as we can get to. And if we can't get to everybody's tonight, Liz and I will take care of answers if you email us afterwards. You can find our information as well as lots of other great things in your folder, including your evaluation form for the night. We'd love to know what you think of tonight, what you'd be looking for in the future, and how we did. So please fill that out for us at the end and let us know what you think. Dr. Thomas, who's the director of the Heart Valve Center over at Northwestern, wants to welcome everybody as well. So he's going to come up and do that now, and then we'll get the night started.
Thanks so much, Colleen, and I won't take but a minute here, except just to say my greetings. Who all in this room has a bicuspid aortic valve? Wow, that's a good turnout. I was doing the math. I think there should be something like 80,000 of you in the city of Chicago. So we've got to get the word out and really there's a lot of folks out there with this situation. Well, I have just started. I'm in about my 6th week at Northwestern. I came from Cleveland Clinic, where I'd been for 22 years, and thought I would retire there. And about a year ago, Pat McCarthy, who directs the Bloom Cardiovascular Institute, dropped me an email to ask if I'd have any interest in the Heart Valve Center, and it sounded interesting. And I came out, and I was just so very excited by the people I met here, the projects that were ongoing, the patients that they have here, really the energy that I found in this place. And also Chicago's not such a bad place to live either. And my good Norwegian wife was only too happy to walk away from Cleveland and come to Chicago. So I don't want to take any more of your time. I'm just so pleased to be here with working with my co-director, Dr. Malaysia, over there, and all the other folks in Northwestern, Dr. Puthamana, and I hope you have a wonderful evening. Please do ask all the questions you can, and if you ever need further help, you know where to find us. Thanks very much.
Thank you, Dr. Thomas. All right, so Liz and I are going to start the evening with a sort of rapid-fire overview about bicuspid valve. We assume that you guys all have a pretty basic knowledge, but what we're going to do is give you a little bit more of that basic knowledge, and then this information will be built on throughout the rest of the night in the various talks. Okay, so what is bicuspid aortic valve? The normal aortic valve, which is the main valve that separates the heart from the rest of the body, normally has 3 leaflets, or is trileaflet. In a bicuspid aortic valve, while in utero, 2 of the leaflets are fused together to create a 2-leaflet valve. So instead of having the 3 leaflets, 2 of those come together, and you tend to have this more fish-mouthed valve as opposed to a nice open valve. I'll have pictures in a minute. It affects about 0.5 to 2% of the general population. So that might not seem like a lot of people, but it is actually the most common congenital heart defect. If you know 100 people, it's likely that 2 of them have bicuspid aortic valve. Unfortunately, it affects men more often than women, usually at about a ratio of 3 to 1. It can also be associated with changes and likely enlargement in the aorta. So here are the pictures. On the top, you'll notice a normal tricuspid valve that has 3 distinct leaflets separated. And then underneath that, you'll notice that that 2 of those leaflets have been fused together, and you actually have this kind of oval fish mouth opening. We discussed that bicuspid valve is sometimes related to changes in the aorta. So this is what a normal aorta looks like. The aorta is the main blood vessel that comes off of the heart and transports blood from the heart to the rest of the body. In bicuspid aortic valve, there are times where instead of being a nice tube, there's balloons bubbling, aneurysm, enlargement, things like that. So it's important that patients with bicuspid valve are also aware of that and that their doctors are monitoring that appropriately. So if you've been diagnosed with bicuspid aortic valve, what should you do? First and foremost, you should find a cardiologist that you like. You're going to be with them for quite a while. So basically, the best thing you can do for yourself is find a cardiologist and follow up with them regularly. We have a pretty great team here, if I do say so myself, but cardiologists they're all over the place. So find one you like. While you see your cardiologist, they will likely suggest that you come back at routine intervals and also that you get testing at certain intervals. So testing that is usually done for patients with bicuspid aortic valve includes echoes, which is an ultrasound of the heart, CT, which is kind of a 3D X-ray, if you will, and then MRI, which is a test that uses magnets in order to give us a nice 3D picture of the heart and the surrounding structures. Finally, you should encourage your family members to be checked out with an echocardiogram. So bicuspid aortic valve is thought to be an inherited condition, and it tends to run in families about 10 to 30% of the time. So while it's not a huge amount, it does warrant some checking out, and most valve experts, including ours here at Northwestern and Lurie, recommend that your first-degree family members, parents, siblings, and children have an echocardiogram to check.
So patients who are diagnosed with a bicuspid aortic valve come in many different shapes and sizes. So your fusion of your leaflets can be in different positions, and the things that are associated with it can be variable. So you don't have to have all of them, but you can have some of them or none of them associated. So some of the things that can go along with it is something that we call aortic regurgitation or aortic insufficiency. All that means is it's very fancy words for saying that the valve leaks. So when the valve actually closes as opposed to it kind of sealing completely, there's a little bit of space in there that allows blood flow to go backwards through the heart, making it a little bit less efficient than what it should be. Some patients with bicuspid aortic valve can have narrowing of the valve, or aortic stenosis is our fancy words for it. And all that means is that the valve is more narrow than what it should be, and it prevents blood flow from flowing nicely out of the left ventricle, or the main pumping chamber of the heart, and into the aorta. And so sometimes when you have that narrowing, it causes the blood flow to, instead of being nice and straight, to kind of have different swirling patterns and be more eccentric than what it should be, which may lead to some of the changes that we see with aortic enlargement or cause some of that. And then Colleen already kind of touched on this, but aortic enlargement or dilation just means that the aorta is a little bit bigger in some areas than what it should be for your actual body size. And eventually, if it gets big enough, it kind of forms an aneurysm, which then can put you at risk for a dissection, which is a fancy word for a tear in the actual lining of the aortic wall. If anyone experiences a dissection, it's pretty rare, but it can happen. It's just a tear, and that can be a medical emergency where you would need to be seen in an emergency room as soon as possible to get treatment. Coarctation of the aorta is something that we tend to see a lot in children, and it's more so because that's where it's diagnosed the majority of the time. It doesn't mean that it can't happen later on in life. But as opposed to the actual narrowing of the valve, the coarctation of the aorta is a narrowing in the aorta past the aortic valve. And so that's preventing blood flow from getting from the top half of the body to the bottom half of the body. And as you can imagine, you need blood flow kind of to go down to your organs and your kidneys and everything to make sure that they're working properly. So we find that that's usually a surgical or procedural intervention to kind of take care of that. And then infective endocarditis is another fancy word meaning that it's an infection in the heart. So Sometimes patients, depending on what their valve looks like, they may be at a little bit more risk for that. So it's important to make sure that you're talking to your cardiologist to determine whether that's something that is meant or needed for you or your child or your relative that has bicuspid aortic valve. So symptoms, in general, symptoms, especially in pediatrics, are really quite rare. Most of the time, our kids, and I would say probably most of the adults too, don't have any symptoms or don't experience anything. So that's a lot of times the norm. But sometimes you can experience things, and it's important to know if you are experiencing symptoms, what it can mean and what you should do about it. So a lot of people have a heart murmur. It's not necessarily a bad thing. It just means that it's an abnormal heart sound, of blood flow in the heart. So some people have heart murmurs for completely no reason at all and have structurally normal hearts, and then other patients can have it related to structural problems like a bicuspid aortic valve in the heart. Some patients can experience fatigue or just being more tired than usual. You can experience chest pain, shortness of breath or trouble breathing, palpitations or heart racing, and then fainting or passing out. If you experience any of these kind of symptoms, it's really important to make sure that you contact whoever your healthcare provider is so that you can kind of discuss in more detail what exactly is going on and then what should be your best kind of plan of action, whether or not you need to be seen in the clinic the next day or taken to the emergency room or how best to handle that situation. So in terms of treatment of bicuspid aortic valve, I think the most important thing you can do is a lot of the same things that we're going to tell all of our patients, no matter what they have, and is to lead a healthy lifestyle. So make sure you're getting out there and exercising a lot, a heart-healthy diet, so low cholesterol, low sodium, all those good things that we all try to strive to do. Losing weight if you need to, smoking cessation, controlling your blood pressure, your cholesterol, and then your blood sugar. Some patients do need medications if you have high blood pressure and you have aortic enlargement, depending on how things go, or to potentially help slow the aortic growth. So that's something that is tailored on an individual basis, so it's important to kind of have those discussions about whether your cardiologist or your provider feels that it's necessary to start medications or if they don't feel like it's indicated at that point in time. And then make sure you see your dentist every 6 months. And then some patients may have activity restrictions, so it's important to go over those with your cardiologist at every single visit so you know exactly what you should and shouldn't be doing, because those are some things that may change over time depending on how your echo or your MRI or CT is changing. So you want to make sure that you know exactly what is healthy and safe for you to do. And then for women who are of childbearing age and are planning on getting pregnant, it's something that is not out of the question by any means, but it's something that we really need to work with you on in terms of a medical team. So if you can, as much as possible, make sure that you talk to your cardiologist prior to getting pregnant, because we may need to switch around medications if you're on it. But then we also want to make sure that you're in with a maternal fetal medicine person that feels comfortable treating patients that have bicuspid aortic valve. We want to make sure that we're screening you frequently enough during the pregnancy to make sure that there's no changes in the aorta. And then also you want to get a fetal echocardiogram at some point during the pregnancy just to make sure that the baby doesn't have any more severe or significant heart problems that were passed on from the bicuspid aortic valve, because that would be important for us to know prenatally before the delivery. In terms of surgical options for children, in general, surgery is not usually indicated in pediatrics or in children. Most of the times it's not until much later in life that we have to do anything about that. But a lot of the times it's the same sort of indication. So if you're having symptoms that warrant an intervention or significant aortic regurgitation, significant aortic enlargement, stenosis, those sorts of things are sort of on an individual basis. And then like the aortic diameter, like we said, and then depending on what the needs are. Surgical options and procedural options can vary. So bicuspid aortic valves that do have coarctation of the aorta, those are generally in infancy repaired from a surgical option. And then balloon aortic valvuloplasties if there's significant narrowing of the valve itself. And then we can repair the aortic valves as much as we can or as much as possible in children as opposed to having to replace them in young kids. And then we can do a Ross procedure, which is just moving the pulmonary valve into the aortic position and then putting an artificial valve in that pulmonary position. And then the valve-sparing aortic root replacement is the same as what we would do in most adults too, but again, that's generally not indicated in kids. So I know that was a huge crash course, so in the surgical options, and we did that a lot more in depth the last year. So if you need more information on that, just let us know.
Dr. Fedak's also going to go over a lot of surgical and medical treatment options as well. So if you didn't catch it all in our little brief thing, it's there, it'll come at you again. So for adults, same indications for surgery. If your valve's going to wear out, it's going to likely do it gradually over time. So that's why it's important to kind of watch how you're feeling, see your cardiologist regularly. Also, it's important to get the testing done on a regular basis because we look at everything. We look at how you're feeling, we look at what your echo shows, we look at what your aortic diameter is, we look at how you are and what your life is doing and what is the best thing for you. In terms of common surgical procedures for adult, you have the standard aortic valve replacement, which would be where they take out the complete diseased aortic valve and replace it with either a tissue or mechanical valve. Some adults are also given the option of an aortic valve repair. So that's where the surgeons kind of pull the valve together and make it fit as nicely as it can to avoid further leaking. Also, if you need a repair of your aortic aneurysm, we would check for that prior to sending you to surgery. And then there's a valve replacement option, which is called the Bentall, and a valve sparing option, which is called the David. Names of the procedures aren't really that important. Basically, what you want to do is find a surgeon that's reputable and that you trust and see what options they have for you at the time. What we were doing for patients with bicuspid valve 15 years ago is not what we're doing today. And what we're doing for patients today will likely not be what we're doing in 20 years. Things are evolving, things are changing. So if and when your aortic valve or your child's aortic valve starts to wear out, it's best to cross that bridge when you come to it and see what the best surgical options for you are at the time. So, that's the end of the basic rundown overview. I'd like to introduce Dr. Paul Fedak, who is our Director of Translational Research for the Bicuspid Aortic Valve Program over at Northwestern. Basically, that means that he is in charge of all of our basic science needs, including looking at aortic tissue and seeing what we can learn from that. So welcome and thank you.
Thank you. So that was a pretty quick crash course, and I treat patients with bicuspid aortic valves fairly frequently, and the one thing that I've learned from speaking with those patients is, for the most part, they want to know what's going to happen to me. You know, you get this diagnosis, all of a sudden you find out you're living a normal life, you find out, well, there's something wrong with my heart, but I feel fine, I'm doing okay. And you know that you've got this problem, but you don't know necessarily what's going to happen to you. What are the risks? What are the potential options for you? So I want to talk a little bit about that, do a bit of education about surgery, when we do surgery and what largely we'll do. Not super fancy stuff, but some of the mainstays of how we approach this surgically. And then I'm going to shift gears a little bit and talk about why you might get an aortic problem from this valve problem. So it's a problem with your valve, but you can also develop a pretty substantial aortic problem that also might require surgery. So we're going to talk a little bit about that problem and the research that we're doing here, some pretty cutting edge research actually, in better understanding why patients develop these aortic problems and then what we can potentially do about them in the future. So I'll go through this now. Now some of this is going to be repetition, but in my experience with patients as well, the more we sort of say things over in different ways, sometimes something might click and you get a better understanding of what's going on. So we're going to try to understand BAV disease and its implications, review some of the optimal surgical approaches, and then highlight some of the key research. So as you know, we have a pretty great heart valve surgery team here. More specifically, I want to go through with you guys the types of heart valves and specific valvular diseases. So you're going to learn a bit in general about what is heart valve disease, what does it do to you, and what are the potential options. Different valve prostheses, so the artificial valves that we might replace your native valve with, and even understanding the operative steps in aortic valve replacement surgery in case you want to try it yourself at home. This is a diagram. So we got to talk a little bit about what happens in the heart and why you even need a valve. So obviously, the heart is a pump, and you've got to pump the blood through your body. And the heart has 4 chambers, and we have to synchronously get this blood all the way through the heart, and we don't want it going backwards. We got to keep propelling it forwards. So that's why all the chambers have valves. And there's essentially 2 types of valves. There's inflow valves that let the blood into the chamber, and there's outflow valves that let the blood out of the chamber. And the aortic valve is an outflow valve. So can you see, is that showing up? Yeah, it is. Okay. This is the aortic valve here. So this is the pumping chamber or left ventricle, and this is the very muscular side of the heart that propels the blood with a lot of pressure all through your body with every heartbeat. So the blood has to get through this aortic valve into the aorta, which is that big vascular structure there. It has to get through there to pump through your body. So it opens with every heartbeat, and then it closes to prevent the blood from going backwards. So that's what the aortic valve does. Now, the aortic valve, if you look anatomically, it sits right here. So this is the aortic valve, and these are your other valves. These are 2 inflow valves. These are 2 outflow valves on both sides of your heart, the right and left. But look where the aortic valve is. It sits right at the very center of your heart. So it's a pretty important structure. So if this valve gets infected, it can cause enormous problems because that infection could spread to almost any part of your heart. And then fixing it can be fairly complicated. So it is an important structure. It sits right in the very center of your heart, and it regulates the blood leaving your heart with every heartbeat. So it's pretty important. So causes of valve disease. So obviously congenital bicuspid is a big one, but you can also develop a problem with your valve just over time. It can become stenotic or start to get blocked over time just from aging. So even a patient with a tricuspid valve could develop what we call stenosis. You can get things with other valves that they prolapse or leak, which can also happen with the aortic valve. And infection is also a main cause that I referred to already. So these are the main things. The valve, really 3 things can happen to this valve. So if you think about what's going to potentially happen to me, these are the 3 worries. One is that it will become progressively stenotic or obstructed, meaning that the leaflets, which are normally like flaps, like thin like pieces of paper, start to become like rocks. So when we go to surgically remove them, sometimes I have to take like really heavy instruments and remove like pieces of rock out of the valve. So it really changes. I mean, it's incredible how this goes from a paper thin, pliable structure to a rock. But it does, and it can do that. Doesn't always, but it can. So, and that's stenosis. Or the valve, as was referred to, can start to leak. So those flaps can become abnormal and blood starts to leak through them, also a problem, or it becomes infected. So those are the 3 things you kind of have to worry about. And aortic stenosis in adults is generally what we tend to see most of. Some of them do leak for sure, but of a lot of you, this may be something that you want to know more about, is progressive aortic stenosis. And as I said, it can happen with a tricuspid valve, but that's a slower process. So we generally see patients with bicuspid valves, they present to us sooner. So instead of coming to us in their 60s and 70s, we might see them in their 40s or 50s, or sometimes even earlier. Because we think that because you're born with this abnormal valve, it's already a little thickened, it takes a bit more of a beating over time and starts to become calcific. We don't scientifically know exactly why this happens, why the valve becomes stenotic, but it certainly does. And when it does, it shows you the picture here of the stenotic aortic valve. It looks pretty ugly. This is an example of a stenotic tricuspid aortic valve. As you can see, there's 1, 2, 3 flaps, and there's all this characteristic sort of crud all over it that causes the obstruction. So these flaps can't open properly because they've got all this stuff on them. This is an example of a bicuspid valve here. So you can see there's 1 flap and 2 here. This is what's called the raphe, or where the 2 cusps that should have been here have fused together. So aortic stenosis, we know, is a real bad problem. So you can go a long time. Let's say your valve is obstructed, it's all calcified, and the blood's not getting through it very easily. You can go a fairly long time. Your heart can adapt, your body can adapt, and you might not feel anything. So you might feel completely normal. But it's there. The valve can still be blocked, but you feel normal. But then if you leave it that way long enough, it creates enormous back pressure. So it's just like if you imagine a garden hose and then you stepped on the garden hose. Well, everything behind that garden hose is under enormous pressure. And that's what happens to your pumping chamber. It's under huge pressure. And that causes, because it's a muscle, it has to work a lot harder. And when you work a muscle harder, what happens? It gets thick, or hypertrophy, we call it. So you start to get a thickened muscle, and that can cause all kinds of problems. It can cause you to have a sudden death episode from a cardiac arrhythmia, where you get a funny heartbeat. It can also cause the heart to fail over time. So if you leave it long enough, the muscle will become damaged and fail. So what we know is that when patients start to develop symptoms, that's when their survival goes down. That's when it's time to do something about this valve, because once you develop symptoms and you have aortic stenosis, you're on a very steep curve to a bad problem. And the kind of symptoms that we're looking for are typically angina, syncope, and heart failure. So what does that mean? Well, angina is chest pain or discomfort. So when you exert yourself, you may get a tightness or chest discomfort. That's often an early sign. Another sign is syncope or fainting. So you might feel faint or like you're going to pass out, or actually pass out in some cases. And then the worst one is heart failure. Once you start developing heart failure, you're pretty advanced in the course of disease. But in general, if you develop symptoms, we should probably, and you have a severe stenotic bicuspid valve, you probably need surgery right away. So what about medical therapy? Say, well, I don't really want to have open heart surgery, doctor, I don't want my chest cracked open, thank you very much. Fair enough, nobody wants to have that. But medical therapy can't fix this. If you think about it, it's a mechanical problem, it's obstructed. There's no pill we can take to clean out all that calcification and make those leaflets go back to normal. There isn't. So it doesn't prevent disease progression, doesn't cure the valve disease. It might make you feel better. So, sometimes your doctors will put you on medications to try to make you feel better, but it doesn't cure the problem, and you're still at risk. So really, surgery is the answer for this problem. So we talked a little bit about when we might want to operate on somebody, but typically symptoms. We often will operate once somebody's symptomatic for any valve disease. There are some cases where if you're feeling completely fine, we still might want to fix your valve. But for the most part, you have to have symptoms before we want to intervene. If you don't have symptoms, but there's signs that your heart is under too much stress. Remember I talked about the garden hose analogy. Well, if we see signs that the heart is starting to get bigger, or the thickness is worse, or the function, it's starting to look weaker with every contraction, then we might say, look, this is putting too much stress on your heart. We don't want your heart to fail. Time to go in there and fix your valve. So the other one is infection. Obviously, if their heart valve gets infected, almost all cases we will operate on that. Or severe valve dysfunction. Sometimes we just find that the valve is so obstructed that we know the risk is high, especially for sudden death. So we then will go on and operate it. And it's incredible how blocked some of these valves can be. Like when we, for most of you, your aortic valve should be about that big. And literally there's many cases I operate on, and I couldn't even get my pen through the opening. I mean, it's such a slow progression that your body has an amazing ability to adapt to it. But it's actually quite scary when you go in and see how narrow some of these valves are. So sometimes in the very severe cases, when we really see it's a pinhole opening, there's no point in waiting for the first symptom, because the first symptom might be you drop dead. So we would operate on you in that case. So repair versus replacement. So many people say, in general, if we can repair something rather than replace it, it's better. And what do I mean by that? Well, repair will mean that we're going to reshape your valve with your own tissue instead of just cutting it away and putting in an artificial heart valve. And repair is often better. So you'll hear about mitral valve repairs, and we often will repair a mitral valve, but the aortic valve is a very complex structure, and it doesn't like repairs as much. Now, in certain cases, we can get a very successful repair, but in many cases we can't, particularly if the leaflets are destroyed by the disease process. It makes sense that, if the leaflets are so damaged, how could we possibly make it work better? We just have to cut it out and put an artificial valve in. So typically, if you have a stenotic valve, it's probably not repairable. If you have a leaky valve, it might be repairable. It might be. Valve replacement, even though it sounds like it's bad news if you have to have your valve replaced, the good thing is that it gives a very predictable and excellent long-term result. And so valve replacements have gone on for decades and decades. We have a huge amount of experience and data. And if you get your valve replaced, is going to work for you for a very long time. So it's a great operation. So don't be too concerned. There is a good solution. Now, what kind of valves are out there? There's lots of different valves out there. And how you select the right valve for you is really a conversation between your cardiologist or surgeon and you. And it really depends on your lifestyle and your age and many different considerations, okay? One thing, so the different types of valves, one type of valve is the mechanical valve, okay? So this valve, here's an example up here. This is made completely out of artificial materials. So it's sort of like a plastic or metal valve, we say. Now, the great thing about that is it won't fail. So this will never really break down. If you look after it, this valve can keep ticking for a long, long time. The downside is you have to take blood thinners. And the typical blood thinner that people take for this is called Coumadin or warfarin, which is also rat poison. And it's exactly that. If you go to the hardware store, you can buy warfarin to kill rats. So obviously this is not a great medication that people love to take. You have to get your blood checked frequently. So people like to avoid this, but it works. And we can certainly get away with doing this. But that's a downside, and there's a lot of people who don't want to take Coumadin and avoid mechanical valves. The other thing about them is they can sometimes create a click that you can hear. So if you're thin patient, sometimes, lying in bed at night when there's no other sounds, you might hear the click, click, click of your valve. And I've had patients come to me and they say, Dr. Fida, I keep hearing this clicking. Should I be concerned about that? And I always say, well, be concerned if you don't hear the clicking. And they don't like that very much. The other option is a biologic valve. So instead of a mechanical man-made valve, biologic valves are essentially man-made to some extent, but they come from animal materials. Okay, so typically we will use a cow valve, which is made out of the pericardium or lining around a cow's heart, or a porcine pig, which is a pig valve, which is the actual pig's valve, but it's made on a stent. So there's still artificial material in it, but the flaps are made out of animal material. Now it's specially treated so your body will not react to it, so you won't need to take anti-rejection drugs or anything like that. Your body doesn't really react to it. And the upside is you don't need blood thinners, so it's great. You don't need to take the rat poison. The downside is that it could wear out over time. So depending on your age, if you get one of these valves and you're 40 years old, it will wear out. You're going to need another valve replacement at some point. If you're 65, you might not. So they can last 15, 20 plus years in some cases. But again, it's sort of, once you're in the 60, 65 range, we're generally favoring tissue valves. If you're younger, we're generally favoring mechanical valves. But again, it really depends on who you are and what you do. If you like to parachute and wrestle alligators and swallow swords, then you might need a tissue valve. So you don't require blood thinners for life. Now, this is an example of some of the data from a typical biologic aortic valve. This is freedom from something bad happening at 20 years after putting in this valve. And this is the freedom from these things. I won't go through each of these, but these are all bad things like it clotting off or falling apart or getting infected, things like that. So you can see that there's over 80, 90% chance that this valve's going to be fine in 20 years. So the results are really good, really, really good. So once you get this biologic aortic valve, you're going to do really well for a very long time. And in fact, the surgical risk, now nobody wants to have this done. It sounds very scary to have open heart surgery, but the risk is extremely low. To lose a patient to replace their aortic valve with one of these valves is extremely low, extremely low. It almost doesn't happen. So, anything can happen with heart surgery, but this is a very safe, routine operation that gives you a very good, predictable long-term result. So this is the good news. Now, you might be afraid, I have this valve, what's going to happen to me? Yeah, there are things that can happen, but the surgical solutions are straightforward and they're predictable, and you'll get a great result. And you can live a completely normal life with a valve replacement. You can go back to complete recovery, completely doing everything that you want to do. And typically, patients who have aortic stenosis and get their valve replaced, they feel amazing. They don't even realize how compromised they were because it's such a slow progression. I've had lots of patients come back to me and say, I feel 10 years younger. which is great. And so I actually really like doing this operation because the patients come back and they're very happy and they do very well. And I know I've made them feel better and they live longer, and that's very rewarding. So how do you do this? There's lots of ways to do this. I'm taking you through the very standard way. Typically what happens is you need to get through the breastbone in some way. Some people do it through a smaller incision, but the standard way is to go completely through the breastbone. It's called a sternotomy. Okay, going through the sternum. And we don't crack it, we don't break it. We use a special saw and we surgically transect it, and it's a nice clean cut, and it will heal back to normal like any broken bone. But it takes 6 to 8 weeks. So you got to take it easy for 6 to 8 weeks after the surgery and allow that bone to heal and fuse together. But once you do, you'll feel better. Now, yes, it's a bit sore for a while, and it'll slow you down for a while, but it does fix. This is the kind of exposure we get surgically. So this is the pericardium, or the lining around the heart, that's opened and retracted. This is the aorta here that we would typically see. This is a part of the upper chamber of the heart called the atrial appendage. And we'll put you on the heart-lung machine through this incision. So we put tubes in your heart, drain the blood out, put it through a machine so that we can stop the circulation of blood through your heart. And then we can open your aorta. So we've got a clamp across this. You're on the heart-lung machine. We open your aorta, identify that valve, and cut it away. Once we cut it away, we put a number of special stitches around what's called the annulus, or the ring around the valve. And then we put those stitches through the valve itself. It has a special sewing ring for those stitches. And then we tie that down and close up, and the valve should sit nicely in that, replacing it. And it should be a low pressure across the valve. So there's certain sort of quality checks that we have, and we want to make sure that there's no high pressure across the valve, that it's the right size for you, that there's no what we call paravalvular leakage. There's no blood leaking through here, causing another leakage, and there's no obstruction to the flow. So you have your coronary arteries right nearby. We don't want to block those. We need to get blood to the heart muscle. Now, there are newer techniques. So you might hear about something called a TAVI or TAVR procedure. It's really quite exciting. Is we're now able to replace an aortic valve without opening your chest. And the way that's done is a catheter with a balloon and a valve on it are run backwards up your aorta with X-ray guidance to the valve. And without cutting that valve away, we expand the balloon and smash it open, and then balloon open a valve that looks kind of like this in that space. And this is really quite remarkable. It does work. It's generally for older patients who have tricuspid valves. So younger patients with bicuspid valves are not ideally suited for this. With time, I'm sure techniques will be developed to address that. But right now, it's not a great option for patients with bicuspid aortic valves. So I wouldn't plan on having this done, as good as it sounds. So I'm going to switch gears, unless there's any burning questions now, but any clinical questions that anybody has? A lot of confused faces over there.
Can you touch on the Ross procedure?
Sure. Okay, so I didn't go through, there's also a lot of more specialized. So the mainstay is valve replacement with one of these valves, but there are some very specialized surgical techniques that are great for certain patients. And so the Ross procedure is a really special one where if you don't want to put an artificial valve, because even the biologic valve is somewhat artificial, right? If you want to actually put a native valve in the replacement spot for your aortic valve, what the surgeons will do is remove your pulmonary valve, and they'll cut your pulmonary valve out and put that over on the aortic side, and then replace your pulmonary valve. So you're still going to get an artificial valve, but it will be on the right side of your heart instead of the left. So it won't be in that high pressure area. And we think that in some cases that may be beneficial to leave a native, it's like it's your own valve. So it doesn't come from anywhere else. So that it's a complex operation, very specialized. It's not for everybody. But in some cases, it can be a benefit. Okay.
And checking for chest pain, how severe and frequent should the chest pain be so not to overreact and say, this is it, I got to go back in, you get it, got tested 3 months ago. Can you kind of give an indication on what, because I have chest pain, but I think a lot of perfectly healthy people feel chest pain.
Yeah, it's difficult. You know, that's a good question. It's difficult to gauge. I mean, this is something that it shouldn't just happen once, you know, and then go away and come back maybe one time 3 months later. If it's a true pain from your heart, the reason you're getting it is that your heart is under all this strain. So whenever you exert yourself or exercise or really work your heart hard, you should feel that same thing. So if it's fairly consistent, then I think you should be concerned about it. If it just kind of comes and goes and it's not very easy to identify, it's a less of a concern. But by all means, I mean, if your symptoms change at all, you should probably get them checked out.
Is tightness similar to pain? Is that the same?
Yeah, I mean, it's difficult to describe. So we have this term called angina, and that can mean a lot of different things. So it often doesn't feel like a pain. We call it chest pain, but most patients wouldn't describe it as pain. They often will describe it as a tightness or a heaviness or a pressure sensation. The classic is the elephant on the chest, but it's highly variable, and it can be very what we call atypical. So it could be something like some discomfort in your neck or jaw that's the equivalent of angina. So you kind of have to find out what it feels like for you. And I find that that's pretty reliable, that, you know, patients who get it and it's coming from their heart, once they get to know what that feels like, then when they get it, they know where it's coming from. And it can be fairly anxiety inducing, because if you're worried that you have, well, it could be anything. Well, what if I have some indigestion? It might feel like that. What if, you know, I've got a bit of a cough and some pain in my chest from that? Or what if I exercise and I've got some tightness in my muscle? Well, is that coming from my heart? It's hard to know sometimes. It is.
What exactly causes the syncopal episodes?
Yeah, so the syncopal episode generally is a lack of blood flow to your brain. So if you remember, you know, we've got a fixed obstruction. So your heart is pumping as hard as it can, and when you exercise, you need to increase the flow of blood through your body. And if you have a fixed obstruction, you can only increase it so much, because the orifice is just too small to allow the kind of flow you need. And at some point, you might be pushing your body too hard, and you don't get enough blood to your brain, and you can pass out. So we'll answer more clinical questions after. I'm going to switch gears to talk about some of the research that we're doing, more about the aorta. So one of the things that we talked a lot about the valve and what can happen to your valve and how we might fix it, but another major thing that we get concerned about patients with bicuspid valves is their aorta. And what we know from pretty recent studies is that the risk of aortic aneurysm or enlargement of your aorta is fairly high compared to patients with a tricuspid valve. So we see a lot of patients who have aortic aneurysms with bicuspid aortic valves. Often they're asymptomatic young patients who have this. It seems to be independent of the valve function. So even if your valve is functioning totally normal, but it's bicuspid, we can sometimes see the aorta getting enlarged. We know that the wall of the aorta is abnormal in this situation. It gets degenerated. I'll show you some pictures of that. The causes and mechanisms of how this happens, we don't know exactly. And it's one of the main areas of research that we're working on here. This is what your human aorta looks like if you were to take a sample of it and look at it under a microscope. There's three important layers. The adventitia is the outer layer, which gives some strength. The intima is the inner layer, which gives a communication between the blood and the vessel wall. And the media is the thickest or muscular layer. And this really allows tone. It allows the aorta to contract a little bit. And it's really where we think the problem arises when the aorta gets dilated over time. So if we zoom in on that a little bit, you can see that it's highly organized. So there's a really beautiful organization of these layers. And these layers are special fibers, so they're wavy like this, and they're made out of collagen and elastin, and they can absorb a lot of stress. And these layers are really important to keep the strength of the aorta. You can imagine it's under enormous pressure. Enormous pressure with every heartbeat. If we look in a little more detail at that, there's really a number of layers here. So there's the smooth muscle cell layer, there's an elastin and collagen layer, and then there's little microfibers that are made out of something called fibrillin-1 that attach it all together. And this is really the functional unit of your aorta. And what happens in patients with a bicuspid valve is we find, and this is some actual human microscopy segments. So this is a patient with a normal aortic wall who has a tricuspid valve, and this is a patient with a bicuspid aortic valve. And you can see the difference here. So this black stuff is the elastin layer, and I showed you how that's supposed to be nice, consistent layers. The red are the smooth muscle cell layers. You can see how different it looks in a bicuspid patient. It's all fragmented, it's thinned, there's loss of the muscle cells. So it's significantly affected. We did some studies many years ago where we tried to better understand what's going on in this wall, and we found that fibrillin-1 levels were decreased in the bicuspid patients, and although elastin collagen levels were the same, they were clearly disrupted. And we believe that part of this mechanism may be that there's loss of these attachments, and when the cells become detached from their local matrix, they release MMPs, and MMPs are enzymes that actually break down the vessel wall. And when the cells get detached, they die. So this may be why we're seeing some of these histological changes. But what's really interesting with patients with bicuspid valves is they're all different. And, you know, they present differently, and some patients with a bicuspid valve get an aortic problem and some don't. And some get a very mild aortic problem and some get a very severe aortic problem. And we don't know why. We don't know why there's such a variable distribution of these patients. And the big debate is, are you born, because you're born with this bicuspid valve, are you born with a problem with the aorta, and then we see it over time? Or is the aorta a consequence of the abnormal blood flow through this valve? We don't know the answer to that, but we're trying to find out. And what's interesting is that, yes, the patients present very differently, and some of the newer work is trying to look at the actual fusion pattern, because there's different ways that that valve can become bicuspid. They don't all look the same. And it may be that the fusion pattern affects the blood flow pattern, and that's what's creating the changes in the aorta. So here are some examples of how it can look depending on where it fuses with those three leaflets. And a typical one is this anterior, posterior, or right-left fusion pattern. That's typically what we see 86% of patients. Also, the sizes of these flaps can be very abnormal, and this may influence what happens to patients. So unequal sizes is most common. And if you think about what might happen, it kind of makes some sense. If you think about, you know, a faucet or blood flow through a hose, if it's a nice, perfect opening with no areas of obstruction, you get nice, what we call laminar flow. The flow is very organized and goes in a straight line like that. But you can think about, even if you just put your finger slightly over that hose, what happens? Well, you get a very chaotic distribution of flow. And for the first time, we've got technology now that we can actually look inside your body and map that flow pattern and see what's happening in real time with the flow through your bicuspid aortic valve. And we did a study where we looked at the pattern, the fusion pattern, and the blood flow pattern, and we correlated that with the degree of aortic dilatation or change in the aorta, and it started to fit some patterns. So this is some of the first data that's really clear data that's indicating that the abnormal blood flow through your bicuspid valve might be an important trigger to the abnormalities in your aortic wall. And this is what some of those blood flow patterns look like. So you can see it's pretty sophisticated, where we can see these red spots where there's increased stress in the wall of your aorta. And here's an example here of actual patients that we've done. On the left is a normal aorta, so you can see the blood coming out of the pumping chamber and going all the way through the aorta to the body. And you can see in that situation that it was fairly uniform flow. There wasn't a lot of red spots. I'll run that again. So there's some red coming through the valve, but over here, pretty nice, consistent flow. This is a patient with a bicuspid valve, and if you look right over here, there's this really abnormal red flow here. So there's a funny jet there, and we think that probably those jets are creating tension on the wall, and that's creating some wall stress. But now with this 4D flow MRI, we could map out these spots, and if it is true that they're a cause, we might be able to better treat you as an individual. Instead of treating everyone the same with a bicuspid valve, we can look inside and say, well, listen, you've got a really bad spot here, and that might be something that we need to deal with. So some of the important gaps in our knowledge are, is this a genetic problem that you're born with in the aorta, or is it really hemodynamics, or is it both? And then if we can figure that out, we can better understand when we should operate on somebody to prevent a future problem and what procedure we should do. How aggressive should we be when we're in the operating room to remove these parts of the aorta? And I did a study where I did a survey of 100 cardiac surgeons to better understand what their approach is. And we do have guidelines for how to treat patients, but interestingly enough, there was a widespread variability in how the surgeons were treating the patients. And in some cases, that can be a little concerning. So 52% of the surgeons I polled believed that genetics were solely responsible for this aortic problem. Only 2% believed that valve hemodynamics were really the problem. And that might change how aggressive a surgeon might be with you. So if a surgeon that you talk to believes that this is something you were inherited and your whole aorta is bad, they might do a very aggressive, big operation to replace your entire aorta. That might create more risk for you than is necessary. We don't know yet. We're trying to sort all of this out. So how does this BAV aortopathy or aortic problem happen? We think that to some extent there's abnormal blood flow patterns as we've been mapping with the 4D flow MRI technology. Those are causing molecular and cellular changes in the wall, in that media layer that I showed you, creating this kind of scenario where you're getting release of those enzymes and breakdown of the wall. So we're doing a really interesting study right now, and actually we're going to be presenting some of this data at the American Heart Conference, which is going to be right here in Chicago in November, where we've done a number of 4D flow MRIs on patients who are going to have surgery for their valve and aorta. And we did a 4D flow MRI study of the blood flow patterns, and then we collected their aortic tissue that was resected at the time of surgery. And then in my laboratory, we've been studying a number of the things like those histologic changes or the changes in the vessel wall. We've been doing biomechanical analyses, trying to better understand how weak is that aortic wall, what does the look like, what are the cellular and molecular changes, and trying to clearly identify those and correlate those with the changes we're seeing on 4D flow and MRI. And for the first time, we're demonstrating that these hot spots on the 4D flow MRI clearly do reflect changes in the aortic wall. And that means that in some ways we're validating this technique, and we may be able then to apply it to patients to change their management towards a more personalized approach, which I think is going to be important. Thank you very much.
Our next speaker is Adam Pick. He is coming to us from out of town to join us today. So he's a patient that has a bicuspid aortic valve and is an author, and now runs HeartValveSurgery.com. So he's going to tell you what he thinks he needs to know from a patient's kind of perspective.
Thank you so much. So you've heard a lot of information tonight, right? Symptoms, disease, stress strain, angina, symptoms, disease, stress strain. And I have a question for this side of the room. I need your help. So I'm going to ask you to raise your hand if the answer is yes. Are you ready to have some fun? Okay, right on. So this side of the room, even the no film zone, I'm going to ask you the same question. Are you ready to have some fun? Okay. So to do that, I need to get the slides ready. Oh. Other way? And I run a website.
Just use the,
I got it.
yeah, just use the keyboard, and you can use the arrow.
Great. So how do we have fun a lot of the times? Well, if you ask my son, Ethan, who's 5, he loves to play games. Right? And so we're going to play a little game. But all really good games need what? Who said that? You're right. Okay. So if you choose to play this game and win, you can get a prize. And the prize is a $50 gift certificate to Amazon.com. Okay? So we're going to go to the next slide. And we're going to play a game that I guess most of you already know. It's called Hangman. Do you remember that game? Okay. I'm not going to show it to you yet, but what you're going to do is you're going to yell out the answer, and whoever yells out first wins the prize. Very simple, okay? And in doing so, you're going to learn a little bit about me, okay? So here we go. Here is the board. The question is, what does Adam pick? Okay? Are you ready? Are you sure? All right, here we go. First one who yells it out and yells it out loud wins. Who said that? Wow, that was incredibly fast. And flip. And that was, you did really well on your SATs, didn't you? So it's true, you're looking at a complete fluke. And really the reason I say that is if you were to ask me 5 years ago, where would I be today? This is the last place on earth that I would tell you I would be. Now, that doesn't mean you're all nice people and I have something against you. It's just I never expected that this, what you're going to hear, happened to me all because of a bicuspid aortic valve. Okay? So let's go on. As this fluke, what has happened is that I've become what they call a patient advocate. Okay, and looking out here again, how many of you are patients? Raise your hand. And how many of you are family members? Raise your hand. And how many of you are friends of patients? Okay. Oh, there we go. Okay. So this fluke, I'm able to talk with a lot of you. And at times, I'm able to help you. Here's Rick. Did my best to help Rick. Ned, did my best. I see Eric and Justine in the background. Really wonderful. Question for you, has anybody here been to HeartValveSurgery.com before? A couple people. Okay, great. So that helps. So this fluke, strangely enough, a couple years into it, we start working with some incredible organizations. And one of those organizations is Northwestern Medicine. I can't tell you what a gift it is to be here tonight with you, to have this opportunity to share this experience, because these people are committed to your health in a way that you cannot imagine. And along with the logos that you saw up there are the people. And this, again, as part of the fluke, we have joined forces with some of the leading valve therapists, and these are folks that I talk with, I'm blessed to talk with every day as to how we can help people like you, okay? So the question is, what happened to Adam? How did he get here? What's this fluke thing all about? And I'll tell you that, like many of you, like you heard tonight, this is me. I am 5 years old. My team was called the Goal Kickers. And my mom said to me, after a meeting with my primary care physician, you have a little heart murmur, is what she said to me, and I didn't think anything about it. And what did I do? I went on to lead a very, very normal life. I played sports, I went to school, I got my degree, everything was normal. And then I moved to Chicago, and I had a meeting with Dr. Davison. This is back, I'm 26 years old at the time, I think. And he says to me something like this: you have a bicuspid aortic valve with aortic stenosis, and maybe in 20 or 30 years, we'll do something about it. 20 or 30 years. And so you know it again, I'm 26 years old, and he says, and I want you to take some medicine to help you through this. And take a guess how I reacted to this. Anybody? What? Yeah. Freaked out. Actually, you know what? This is going to sound weird. I didn't really care. 20 or 30 years? I'm 26. We'll take care of it then, right? And so Dr. Davison was right. Something was going to have to be done, but it was going to have to be done much, much earlier than 20 or 30 years. And so in 2005, I'm building a business of mine, and I go out for chips and salsa at La Playita in Hermosa Beach, California, with my girlfriend at the time, who would become my wife. I'm going for my third chip, and I love chips and salsa. And I take a bite, and all of a sudden, the left side of my body goes numb. And my wife is a brilliant woman. She knows that myself and most men, we don't like to be told what to do. So she didn't say to me, tomorrow you're going to the cardiologist. She said to me, will you please go to the cardiologist tomorrow or get an appointment? And that's what I did. I went and I got an echocardiogram done. And then I met this guy, Dr. Bad Bedside Manner. And I'll never forget this. I'm in the consultation room. I've just been called in urgently by my primary because they found something on the echo. He walks in. He opens my chart. He looks at me, looks back at the chart, looks back at me, and says, you need a new aortic valve. Do you have any questions? Never went back to Dr. Bad Bedside Manner. But he was right. I needed to have my valve replaced. And so what did I do? This is going to be maybe shocking to some of you. The next day, I got on a plane, because I told you I was building a business. I had this huge business trip in Europe. I went to Europe for 2 weeks. Is that a smart idea when you've just been told you need open heart surgery? No way. And I ended up in Amsterdam at a hotel, completely freaking out. That I was, what's the term, decompensated? I don't know the term with the heart. I just felt like I was collapsing. I cut my trip short. I got back on a plane, and I came home, and what I did was I did this, right? And if you've been diagnosed with this disease, any serious disease where you can have a major surgical event, are you happy? Are you excited? No, typically most people worry. And this is what I worried about. Will my surgery be a success? Do I really trust my surgeon? How long will the recovery take? And then, what about these complications I've heard about? Are those going to happen to me? And so, I look at problems in my life as challenges. I look to overcome them. I'm an optimist, right? And so instead of worrying, I got to work in doing research. And what I found when I went to the internet was something that was a little bit scary. There's a lot of information. Some of it is very good, and some of it is maybe questionable. And I got overloaded. And I'll never forget, one night my sister, one night my sister, because you know how it is, right, family members? You want to do all the research too for your patients, so you're giving them all the information when they're getting the information. And my sister called me up and she said, Adam, are you sitting down? It's my sister Monica. She said, are you sitting down? I was like, yeah. She said, I think I have some really good news. And I was like, what? She said, I've been doing research, and the odds that you're going to die are very small. And so, you know what I did? I waved a big white flag to my friends and family, and I said, I surrender. Don't call me anymore with information. Don't send me the links. I'm going to handle this, and I'm going to go about this a very pragmatic way. And I did. And I'm very lucky. Somebody raised a question about the Ross procedure. 45 days after this experience and the diagnosis, I had the Ross procedure done. And again, what they did was they took my aortic valve out, the diseased bicuspid valve. They switched over the pulmonary to the aortic position and put in a donor valve. And I had this procedure done at USC Medical Center in Los Angeles by Dr. Von Starnes, really nice guy. And what happened after surgery? I did great. I did really, really great. It was alarming to my family how good I was doing. And that was about the first week. I was doing really well. But what happened afterwards, you know, they tell you the recovery is 6 to 8 weeks, and I've done research on this and we've done surveys. It's not always so specific. Everybody's healing is a little unique to them. And so if you hear generalizations as you go through this process, just remember you're unique. And that's the great thing about life, right? We're all unique, and so is your healing, okay? And so in terms of recovery, what happened to me, about 2 weeks into it, I found that I was taking a little too much Vicodin, and that continued. And then what happened to me is I started having chest pain, discomfort as I got off the Vicodin. So what did I do? I took more Vicodin and started not having the best normal thoughts about my recovery and who I was and what heart surgery meant to me. And I entered full-blown cardiac depression. I was depressed. I'm a type A personality. I had a beard going. My mom and dad did an intervention. They got me to a pain management specialist to help me out. I was just not in a good way. And so my support group, as I just said, they intervened. And if you have a support group, which it seems like many of you do, I can't emphasize to the family members and friends to really help your patient, your loved one through this. It's so important to listen to them as they go through this and experience heart surgery. And so anyways, the turnaround for me came in cardiac rehab. Has anybody here heard about cardiac rehab before? Anybody here been to cardiac rehab before? Okay, so Rick, what was your experience at cardiac rehab?
It just lets you know that there were other people who are going through what you're going through. I mean, you're not doing it alone, and you could ask questions to other people, and they would ask questions to you, and you kind of would compare notes, and it gave you kind of a calming feeling.
Mm-hmm.
And I know people who had this surgery I've talked to before who said, I don't need rehab. And you know what? More so for here, a lot is for here. At least that's what I found out.
Yeah.
And I think it was a good thing.
Yeah, so the benefits, and anybody preparing to go into surgery, I often recommend that before you even go in for the surgery, know that you've got a cardiac rehab program in place for the recovery. Because the benefits, and there's been research done on this, social benefits, physical benefits, spiritual and emotional benefits. So right in line with what Rick was talking about. But what was interesting was I was in such a bad way, I ended up in therapy for this. And about 9% of patients actually end up in therapy to discuss this matter. And one day I was with my counselor, and I said to her, you know something? I can't be alone in this process. Why doesn't somebody write a book to help patients? And she looked at me, and she said, you write it. Why don't you, is what she said. And I said, I don't do that. I'm a high-tech guy. You know, I'm not about self-help. And she said, well, don't do it to publish it. Just do it for catharsis. So I went home that night, went to my office. I just started writing. 2 chapters later of this book that didn't exist, I walk out and I give it to my wife. 20 minutes later, she comes running back in. She literally puts the paper down on my desk and she says, you need to do something with this. And I looked at her and I went, really? And she said, yeah, give it a shot. So I went ahead, I finished the book, I did some research, did some online research, did some surveying of patients, found out a lot of information, and sure enough, put out this book called The Patient's Guide to Heart Valve Surgery, and it was helping patients in 50 countries within the first 6 months it was available. Really just a fluke, right? And so then what happens, long story short, we start building a website around the concept of education and empowerment of people like you. We want to drive up awareness. We want to make sure you're educated. You understand what this potential black box of surgery is about from the patient perspective. And this little website now started off as 3 pages. It's now over 6,000 pages of content. We have a social network where you can relate to other patients in Chicago or New Zealand or Bangladesh. We have a blog, we have a surgeon finder, we have a heart hospital directory, and we have a video section. I wonder where this video is going to go, right? And so the goal really is education and empowerment, and that's our platform, and this is where it just becomes relatively silly. Last year we had over 900,000 visits to the website. And we live in a world of billions and zillions and millions, but if you think about that, there's only about 250,000 of these procedures done every year. So this is a community. They're there to help you, your friends, and your family. And so our goal is education, interaction, and community. And when you roll those things up and you bundle them together, my hope and my dream is that you will feel empowered through this process, okay? And lastly, I can't stress to you enough how wonderful this team is here at Northwestern and Lurie's Children's Hospital. The extent to where they will go and the resources they will commit to advance the treatment, the research, and the management of your disease is unbelievable. Earlier today, I was in a bicuspid aortic valve meeting where they get together every quarter to talk about their program. The ideas, the research, it is unlike most organizations out there fighting this disorder. So with that being said, I want to thank you so much for all of your time. It's a blessing for me to be here, and I guess now we'll take a break, and then we'll reconvene in, well, do you want to?
So we'll take a short break now, and then we'll come back about 8:20. Feel free to get food. There's plenty of stuff out there, more drinks. The restrooms, again, are back by the registration table if you need it. Make sure you write down all your questions on the cards. Colleen and I will come around and collect them while we're during break, and then we'll come back and do the question and answer panel.
All right, so we're going to get started with our question and answer panel, and I just want to briefly introduce the panel. First, we have Dr. Young, who is a pediatric cardiologist. Then next to her is Dr. Robinson, also pediatric cardiologist. Dr. Puthamana, who's the medical director of the BAV program over at Northwestern and an adult cardiologist. Then Paul Fedak, who you all know, cardiac surgeon extraordinaire. Adam, patient extraordinaire, and then Dr. Chris Malasry, the surgical director of the bicuspid valve program at Northwestern, cardiac surgeon, also extraordinaire. So we've compiled all your questions, and there's a few themes that have come up, and that we're going to get started with. Oh, and we have more. So Liz will get those. One more housekeeping thing. Could everybody just pass their filming consents to the middle? Like right here, so we can just pick them up. Thank you. Surgical. Yep. Oh, more. Okay, so the first question is likely primarily to the surgeons. We had a few people wondering if, number one, everybody who has bicuspid valve, will they all need surgery? Number two, what can you do to prevent your need to have heart valve surgery? And then three, how can we predict, especially for patients who are in their young ages, in their infancy, how can we know when they will need surgery? Can we predict when it's going to happen?
Well, aren't these like the top 3 research questions we discussed this afternoon, Paul? So I think just for statistics, we would say that over your lifetime, half the patients with bicuspid aortic valve at some point would need something done either to the valve or the aorta. The other questions are actually very pertinent research questions. Dr. Fudak can answer that.
Right. So I think it's important to understand that just because you have a bicuspid aortic valve does not mean you're going to for sure have surgery. So that's important to know. I think the other important thing to know is that you want to get ongoing follow-up. So you want to be, ideally we would say, be part of our bicuspid valve clinic where you're going to get specialized follow-up, but you want to get some kind of routine imaging. And typically the imaging you're going to get is an ultrasound of your heart or an echocardiogram, which really gets a good look at how your valve is working, how stenotic or blocked is it, how leaky is it, and how is that progressing over time. Also look at the size, shape, and function of your heart, because as I said in my talk, that if your heart starts to look like it's suffering, like the muscle, that might be a time that we want to intervene. So the echocardiogram or ultrasound is a key component of your ongoing follow-up. So you're going to want to get that routinely, maybe once a year, depends on what your cardiologist or program wants you to do. The other thing you're going to want to get is an assessment of your aorta, because not only the valve, but the aorta can be a problem. So you're going to want to get some kind of imaging. And the echocardiogram is not great to look at your aorta. So often we'll get a CT scan or an MRI, where we want to look at the size of your aorta and follow that over time. So that's really the general follow-up, and that's for adults. Do you want to address maybe for the kids? Is it any different at the Children's Hospital or?
No, actually, that brings up a very good point. I think regular surveillance is key here. So what you want to do, there are actually guidelines that we follow for imaging, and dependent on what your valve is looking like, how it's functioning, we may want to follow the child a little bit more frequently. But typically we'll get an echocardiogram on a yearly basis. If there are any concerns or significant changes, then we may consider getting an MRI. Fortunately, in small children, we can see most of the aorta, most of the structures that we need to see in terms of looking at function, chamber sizes, et cetera, on the echo because of the small, body size. But as children grow into adult size, it becomes a bit more difficult. And also, echo is only a two-dimensional image, so we just can see the aorta in one plane, and it becomes more important, especially as children grow up and become young adults, to visualize that aorta in a more three-dimensional image area, because you want to see other, asymmetric areas that might also be missed on an echocardiogram. So typically as they get older, an MRI may be necessarily either every couple of years or every year, depending on the individual.
I'll just address the question also about predictions. A lot of people want to know, am I going to be the one who's going to need the surgery? Am I going to be the one who has the aortic problem? We don't have great predictive tools yet, but we think that some of the work we're doing with the 4D flow MRI and by analyzing patients' tissues, that we're going to, and also following them in our clinic, and doing analysis of their outcomes and looking at their echoes and things like that. We think that with our research, we're going to be able to develop those predictive tools. There may even be blood tests we can do. We're taking blood samples and we're looking for what's called biomarkers. So things in your blood that might be predictive of how bad your aorta or valve may be. So with time, we're hoping that we'll figure that out. And that's a key component of our research group here at Northwestern, is to address that exact question. I think that was all the questions.
Yeah. So if you have a bicuspid aortic valve, when is antibiotics for dental procedures indicated?
So with the older guidelines, bicuspid aortic valve by itself was an indication for endocarditis prophylaxis. With the HAACC update in 2008, they removed routine prophylaxis for bicuspid valve anymore. So the only patients who have ongoing indications for antibiotic prophylaxis are patients who have had an episode of endocarditis at some time in the past, patients who have a history of rheumatic fever or a history of endocarditis, and all patients who have undergone valve replacement are obviously candidates for endocarditis prophylaxis during dental procedures.
Is it the same in children?
Or less.
Yeah. Okay. So our next question is about TAVR. Why is TAVR only indicated for older people? And what are your thoughts on having a tissue valve placed in your 40s or 50s with the anticipation that TAVR might be available for a valve-in-valve at some point?
This is really coming from the audience. Huh?
It is.
Really? Adam Pick doesn't ask me questions this often. Okay, so for transcatheter aortic valve implantation, the reason it's a good option for high-risk patients is because it's a newly investigational device which was recently approved, and there are important trade-offs. TAVI or TAVR is approved for tight valves, so aortic stenosis. And both TAVI and standard aortic valve replacement will prolong patients' lives in the same amount, but there's important differences. The TAVI valve, the TAVI procedure, is associated with a much easier recovery. So there's no doubt about that. There's no need for cardiopulmonary bypass to pump. However, there's important trade-offs. Because the TAVI valve, we don't actually sew it in. We put the new valve on top of the old valve. There's a chance that some blood can leak around the TAVI valve. So the TAVI valve is associated with about a 10% rate of leakiness around it, as opposed to about 1% with the surgical valve. So that's one important trade-off. The second important trade-off is that there's a slightly higher risk of major stroke associated with TAVI, and that number is around 3% for TAVI compared to 2% with ABR. So in high-risk patients who otherwise would not make a quick recovery after open heart surgery, I think it's a fair trade-off. So I think TAVI is a good trade-off for older patients. But for young patients in their 40s or 50s, I don't think it's worth the trade-off for a leaky valve or a slightly higher risk of stroke. I think the surgical valve is a lot better. What was the last question? The valve?
Valve and valve.
Valve and valve. And then we also need to discuss why VAV is a contraindication for TAVR at this point.
All right, so currently bicuspid aortic valve is a contraindication mainly for anatomic reasons. The bicuspid aortic valve, when you put something circular into it, will tend not to look like a circle. The bicuspid valve will open up and look like an ellipse. Because of that, we think there's going to be a higher risk of leakiness around that valve. So that's just anatomically, the TAVI valve, which is circular, will not fit into that ovoid space. Now, the question about valve and valve technique, that is still an investigational procedure. We are, in fact, doing that here, and we're not quite sure if that's going to be a good option. For someone who's 40 years old, in fact, the American Heart Association would actually not even recommend a tissue valve for someone 40 years old. They would actually recommend a mechanical valve, even though it clicks and you need to be on Coumadin. That is the current guidelines. So the hope of a valve-in-valve procedure, I think, still needs to be investigated before that has any role for younger patients.
So the next question is, what are your thoughts on medications to control increasing of aortic dilation in young children?
So currently, there are no clinical studies or clinical trials out there to demonstrate that being on a medication is going to change the rate of that aortic growth. That being said, some providers have actually opted to place patients on beta blocker therapy, which is an antihypertensive or a blood pressure lowering medication, in hopes that by decreasing the wall stress on that aorta, that perhaps that will slow down the dilation of the aortic structure. Well, I won't go into adults, but typically, unless someone is hypertensive, there are no clear indications for that, although providers have opted to place patients on beta blocker therapy hopes that that will slow it down. Josh, do you have anything to add?
I was just going to say, I think this is something that's of particular interest for Dr. Young, because she's looked at it in patients who have aortopathy for other reasons. So this is something that our program at Lurie is really investigating, the utility in children.
And just to add to that, you baited me on that one.
Yes.
We were recently involved in the Marfan trial, which was looking at the effects of beta blockers and another antihypertensive medication in slowing aortic root growth. And this is actually a standard of care in patients that have dilated aortas for other reasons. In this particular case, because of connective tissue disorders, it's unclear. These are two different disease processes here, and so the medications at this point in time are standard of care for the connective tissue disorder, aortic dilation, but not for BAV. But it does beg the question, would it help in this particular age group? So I think this is one area that really could use or benefit to have large clinical trials, not just small anecdotal groups, to look at these, whether or not this benefits patients with aortic dilation.
So we're going to hear more about the results of the study that Dr. Young participated in at AHA this fall. So we're excited to open a new chapter and see how that might apply to a different group of patients.
One of the difficulties is that we don't know why the aorta dilates. We don't know what the mechanisms are. And we also don't know why the valve becomes stenotic from a cellular and molecular point of view. So it's difficult to develop targeted medications for something that you don't really know why it's happening. So the research that we're doing with the tissues is really important, because if we find out and better understand the mechanisms for why these things occur, then we could better target them with medication. So it is possible that in the future we will have medications that will be directly targeting the progressive aortic changes or progressive valve changes, but right now we don't. But the first step will be understanding those mechanisms, in my opinion.
So do we have any research or specific guidelines for things like exercise restrictions? Should all bicuspid valve patients be on exercise restrictions? What do you recommend, and why do you recommend it?
So I'll start with adults, and I think this is a bigger problem in children when parents have specific questions about what kind of exercise. But in adults, we depend a lot on the valve problem. If it's the severity of aortic stenosis or severity of aortic regurgitation dictates a lot about restrictions of exercise. But more importantly, the size of the aorta restricts quite a bit on what you can do in terms of exercise. And mostly there is no restrictions to aerobic exercise for bicuspid aortic valve by itself, irrespective of any of the problems, whether it's stenosis, regurgitation, or aortopathy. The reason I say that is most of the patients with aortic stenosis or regurgitation are, if the valve is significant enough, are going to be symptomatic at the time of with exercise that would kind of lead them to appropriate surgical management. As far as enlargement of the aorta that would restrict exercise, our recommendation is once the aorta crosses 40 millimeters, we restrict weightlifting. And again, there is not a clear cutoff. Most of our data is based on European data, predominantly from Italy and other groups that have followed young athletes who have had routine echoes. And what they've seen is bicuspid valve patients compared to patients with trileaflet valves have a progressive enlargement of the aorta, especially if they're involved in exercises that involves a lot of weightlifting. So our restrictions are primarily with regards to weightlifting and no restrictions to aerobic exercise. Once the aorta enlarges to more than 45 millimeters, then we significantly restrict their weightlifting anymore, even to smaller weights.
I think the decision-making in children is similar in that there are sort of absolute size thresholds of the aorta that would preclude certain sports activities like weightlifting or contact sports. And there are pretty clear, I think, thresholds that most cardiologists would agree that would prevent kids from participating in those things. I think the harder question is in the gray zone or the more mild but progressive disease where kids are growing and we can't draw an absolute line. So we have to rely on kind of indexing to their height and their weight and look at progression over time. And I think that's why kids, more than particularly active kids, do need serial evaluations. And they often need the different imaging modalities that we talked about. And those tools aren't this one and the same. So where an adolescent might have more of an adult technique, the equipment required and the expertise required for imaging a younger child is very different. So we do tailor that decision making to the kid. I think that it also is something that you collaborate with families about. Our goal is always to encourage the most activity at the safest level that we can. And I think that on the valve disease front, we have good news in that we've seen that pendulums swing back toward encouraging more aerobic exercise. As we've seen that we've gotten better at treating aortic stenosis, we've seen that the risk of a sudden or catastrophic event looks like it's less than we thought before. So that's good news for patients that if we treat their valve disease, they could enjoy more activity. With respect to aortopathy, I think that we're learning more all the time from these investigations. And when you're on that milder spectrum, it's a little bit of what kind of risk do parents tolerate and what are the kids' interests and are they shapeable? And also a little bit of individual practice between cardiologists and surgeons. So there's no absolute threshold in that area, and I think it's an ongoing discussion.
And just to add on to what Josh just said, there are no guidelines established for children. The guidelines that are in the literature that most practitioners will follow are guidelines that are set for adults, which are very different. We know that in children, the aorta may dilate, but it really is not a significantly progressive dilation. Most of the dilation that occurs is later on during the adult years. So that's one bit of good news. Also, out in the literature, there are no large registries that document that there are mishaps that happen to children or, let's say, young adults less than the age of 18. There are very few documented cases of any problems or mishaps, and the few that are reported are typically in patients that may have a bicuspid aortic valve and some other incidental finding like a connective tissue disorder, which may put them at risk. So I think the biggest one is weightlifting, and for the obvious reason of increasing acutely the blood pressure, which places wall stress on that aorta. That's our biggest one, and other than that, it's very individual dependent based on their aortic valve disease or involvement.
So our next question is more about imaging. So what does an MRI or a CT scan show better than an echocardiogram in patients with bicuspid aortic valve? And then on kind of as a side note onto that is that does your fusion pattern of your bicuspid aortic valve impact your wall shear stress? And how can you tell?
I'll take that. I'm one of the imagers who's collaborated with the group on,
Josh, can you pull the microphone a little
yes, who does CT and MR and collaborating with our group that are looking at these flow patterns in the aorta. So in general, the advantage of cross-sectional imaging or CAT scans and MRIs is that they're not dependent on acoustic windows. So when we use ultrasound to image the heart, we have to, basically get the sound waves between the ribs and image a soft tissue structure. X-ray and magnetic resonance imaging overcome that, so it's not dependent, so you can image anyone with that. The aorta particularly is difficult to see as kids grow and become more adult-like, or just in some people in general. And so MR and CT are much better at looking at those things. The other strength of cross-sectional imaging is that we can make a three-dimensional picture for the surgeons and reconstruct them and reformat them in many ways that can help with surgical planning. And then MRI, which is the thing that I'm absolutely most passionate about, adds an entirely another layer to our ability to image the patient. So we can quantify blood flow in a more precise fashion. We can quantify the function of the heart in a more precise fashion. We can tell you exactly how much blood is leaking backwards across a regurgitant or a leaky valve. And we can even characterize the tissue of the heart if there are other associated diseases with MRI. So it has a lot of functional imaging that echocardiography may not. There are definitely strengths to echo, and you need to have lots of tools in your toolbox, no question about it. And then finally, I think, and most promising is this 4D imaging that we're doing. You'll hear it referred to as 4D flow, where I think it, as Dr. Fedak said, it takes another step. Instead of looking just at the size of a blood vessel, we're looking at alterations in blood flow and getting more insight into, well, why is the aorta enlarging? Do we think it's going to enlarge it faster than another? And then I think that kind of dovetails nicely into the second part of the question, which is, does your fusion pattern predict flow patterns or the shape of your aorta? And I think that our group has shown very nicely that your valve morphology, the structure of your valve, does predict changes in the thoracic aorta and the aorta in the chest, and that while it's not an absolute thing, while this disease is very heterogeneous, as we've said before, we do see that there are different patterns of disease and different patterns of thoracic aortic morphology associated with valve fusion patterns.
This question is for Adam. How old were you when you had your surgery?
So I was 33 years old. And I'd been diagnosed with aortic stenosis when I was 26. And I went from being moderate to severe during that period of about 7 years.
So we have a question about advancements in mechanical valves that either do not require blood thinners or that can use something other than Coumadin. Can you give us a little update on where that technology is and where you see it going in the future?
Okay. So like Dr. Fedak said, mechanical valves have the benefit of being the most durable prosthetic valve. The downside is it's an artificial surface and it is prone to forming clots. So we can reduce the rate of clot formation by anticoagulating, so thinning the blood. So typically we use a drug called warfarin or Coumadin, and we measure the Coumadin effects by a blood test called the INR. And everyone sitting here who's not on Coumadin has an INR of 1. When you're on warfarin, we would target an INR of about 2 to 3 for the aortic valve. Now, there is a third-generation mechanical valve that has already been studied for lower dose Coumadin, and you're free to look that up. I have no disclosures on this company. It's MCRI Onyx, ON-X. I've had very good experience with this valve, and it's commercially available. It's not investigational. And the trial for low-dose Coumadin, meaning a target INR of 1.5 to 2, has been done, and it actually has been approved for Europeans, but the FDA has not approved that. So while you're in the United States, your INR has to be 2, but if you travel to Europe, it can be 1.5. There is a ongoing trial right now whether or not this particular valve can be maintained with no Coumadin at all, simply 2 antiplatelet drugs, for instance, aspirin and Plavix. Now, there's a new class of drugs that are hitting the market so far. There's at least 3. They're called novel oral anticoagulants. So warfarin substitutes, okay? And those have been approved for patients with non-valvular atrial fibrillation and blood clots, okay? It has been studied for mechanical valves. Unfortunately, those trials have been negative. In fact, they were very negative. So the FDA gave it a black box warning. So black box is bad. All right, so you cannot use these novel oral anticoagulants for mechanical valves currently. However, this is just the first round. There's probably at least another 5 drugs coming down the road that will potentially be alternatives to Coumadin in the future, but it has to be studied. So there is the hope out there that your mechanical valve, someone has a mechanical valve in here, right, can be
maintained without Coumadin.
So I just want to add to that from the research point of view. It's not ready for prime time yet, but I think the future is going to be tissue engineered valves. So I think we will get to a point where we don't need mechanical valves at all, and we'll have a sort of a biologic scaffold valve that we either get your stem cells or your cells from your body and create your own valve in the lab and then implant it, or put that scaffolding in, and your body will repopulate that scaffolding with your own cells, and then that will be a long-term solution. Kind of like a Ross procedure, but you don't have to steal it from one side. You can sort of make it yourself. I think eventually we'll get there. I don't know how long that will take, but there's a lot of active research in that area, which is pretty exciting.
So if I have a child with a bicuspid aortic valve, do I need to be screened, and should my other children be screened?
I would say yes. The reason for that is that there is approximately a 9% chance that a first-degree relative may also be affected. And so for that reason, I would get screening echocardiograms done. The other interesting thing with bicuspid aortic valve is not all valves function abnormally, so there may not be an associated murmur on exam. So it may be very difficult for your pediatrician to pick something like this up without doing the imaging. And I think that, you know, given all the importance of finding these things early and surveillance, et cetera, and getting the best care possible, yes, I believe we should be doing screening echocardiograms.
And from an adult perspective, what has been shown is family member may not be only at a risk of just inheriting a bicuspid valve, but maybe at a risk of inheriting an aortic enlargement with the normal trileaflet valve. So when the first degree relative is being imaged, you're looking for other conditions that go along with bicuspid valve. They may have a VST, they may have other abnormalities, but a small number of relatives may just have an aortic enlargement as the only condition that they inherited from their family member. So you're looking at not just the valve, but also the aorta.
For pediatric patients who have a Ross procedure, can we predict what the typical time before reoperation, and then also will the pulmonary valve that's in place will essentially grow? Is there anything else in the heart that might need to be re-replaced or addressed after a Ross procedure?
I think there are several unique considerations for the Ross procedure in kids compared to adults. The first is the durability of the transplanted pulmonary valve into the aortic position and whether that will last an entire lifetime. And we have some evidence to suggest that the durability is good, but we certainly have other disease states where a pulmonary valve functioning as the aortic valve does eventually need to be repaired or replaced. So that's one concern. The other concern is that in order to replace the pulmonary valve, the surgeon has to put in place a conduit, and that conduit where the donor valve is seated will not grow with the patient. So depending on the time when the Ross is performed and how big the patient is might determine if they're going to need another surgery for that. That being said, the risk of conduit replacement is relatively low, but we want to avoid those procedures as often as possible. And then the valve inside of that conduit also has to continue to function, and if it is leaky, for example, could cause right heart dysfunction. Fortunately, we do have a transcatheter valve that is, in most cases, in a conduit able to be implanted without sternotomy, without surgery. So there are big proponents of the Ross procedure in the pediatric population. I think that our center takes the approach that Dr. Fedak mentioned, which is it's an option for some patients in certain situations, and that we consider it on a case-by-case.
So what are the symptoms of an aortic aneurysm? And if you've already had your aortic valve replaced, can you have the aortic aneurysm repaired? And after your repair, do you still need to worry about your native aortic tissue distal to the repair site?
So as far as the aortic aneurysm, almost all patients are asymptomatic. When they have symptoms, it's usually catastrophic. So that's, as was presented in the initial slides, you don't want to have symptoms with an aortic aneurysm because that's an emergency that has to be handled within hours. So that's the unfortunate thing about aortic aneurysms, can remain silent till it acutely presents dangerously. The second question, in a patient who has a bicuspid valve, the big debate in the guidelines that Dr. Thomas was part of was, when do you replace an aorta that is slightly enlarged but not enlarged enough to be replaced at the time of replacement of the aortic valve? And that's a very important research question that we are hoping can be answered by some of the studies here. But that is a concern in patients whose, at present, the American Heart Association and the College of Cardiology recommends that the aorta should be replaced at the time of valve replacement if the aorta is 45 millimeters or greater in adult patients. If it's smaller than that, then the practice at present is to leave it alone, where some of our MRI studies may come into play in those patients to help guide the higher risk patients. But an aorta can continue to enlarge, and that has been shown in 2 studies, that there's a small group of patients who continue to enlarge and may end up needing surgery in the next 10 to 15 years. But it's hard to predict who are the ones who enlarge versus those who don't.
So how common is depression following heart valve surgery, and how does Northwestern handle it? Do they have a cardiac rehab program?
So we completely agree with Adam Pick. We recommend 100% of our patients do cardiac rehab after cardiac surgery, namely because of all the benefits that Dr. Pick, Mr. Adam Pick.
Honorary.
That Adam mentioned. In addition, we also have a cardiac behavioral team here with currently 3. We have 3, right, Colleen? Yeah. 3 psychologists on staff who can help both preoperatively and postoperatively with stress, anxiety, and depression. They focus mostly on our transplant patients, but also see a fair amount of our aneurysms patients as well, because like Dr. Puthamana said, oftentimes it's a surprise to have a diagnosis shoved in your face when you're feeling completely fine, right? But being a half glass full type person, we sort of look at that as, well, this is an opportunity to avoid sudden death, right? It's always a tragedy when you hear of the young football player that dies on the football field. We're able to screen family members and find asymptomatic disease and treat it before it becomes a catastrophe.
I think that the depression is under-recognized, and I think that a lot of my patients have it. And when I follow up with all my patients, whether it's valve surgery or any kind of heart surgery, I think it's pretty common, and we probably need to do a better job of addressing it. But I think it's something that you should be prepared for, and I think Adam's point of having a good social network in place after you go through something like open heart surgery is really important. And I think it's one of those things that you won't forget it. It'll be, you got married, you moved, you got a new job, you had your heart surgery. Like, it's a notch in your life that you won't forget. It's a big deal. It is. But you just have to remember that there are exceptional treatments out there. The risks are extremely low. The outcomes are extremely good. So, be reassured. It doesn't make it easier to go through it, but the outcomes are outstanding. And, yes, there's some bumps along the way, and it's difficult physically and mentally to get through it. But many people do, and they do get through it and get back to their normal lives again. So
Adam, how did you know it was actually depression versus just part of, bouncing back, if you will?
Yeah, so it's a great question. And I don't know that I had the answer. I think it was one of those things with, has anybody here, and I know this is a personal question, but experienced depression of any kind? Okay. Wow, nobody? Okay, a couple people. I don't think it's something that you recognize oftentimes yourself. I think you can go into a psychological state where your normal becomes depression. And so for me, to Dr. Fedak's point, I had a support group, in particular my family, just say, you aren't acting like you. You don't look like you. And I've seen this in other people get depressed. My hair was getting a little longer. I wasn't shaving, as I told you earlier. So there was no indicator for me where I looked in the mirror and I was like, you're a depressed dude, But that's what's so great about having my pitfall to share with you. Because to what Dr. Fedak said, I think cardiac rehab is probably underutilized by patients like us. And I think cardiac depression is underdiagnosed in patients like us. And so there's a physician in Los Angeles who said that it can happen in up to 50% of patients. Now, does that mean it's full-blown depression? No, but it might be some mild form, right? You've just gone through a traumatic event. You might have issues, in particular men in the room. Most of the people who I talk with who go through depression are men. Right? And so when I did some research, I went ahead and I surveyed, I can't remember the sample of people, it's in that book right there, but the number was above 30% of the patients that I surveyed who said that they experienced some form of depression, which is, if I was to suggest there's one big tip in this whole process of being here with you, is be aware of it. And make sure you have a cardiac rehab program like Northwestern has here that you can rely upon, because hopefully you won't have to deal with it, which is a net benefit to your recovery.
So on that note, unfortunately, we have to end our evening. Please fill out your yellow evaluation forms. If you submitted a question that did not get answered, if it was adult related, please email it to myself and I'll ask the experts. I'm Colleen. My business card is in everybody's folder. If it was a pediatric question, go ahead and email it to Liz and she'll get the answer from the pediatric experts. Otherwise, thank you again for coming. And if there's anything else, we're here and we want to hear from you. So thank you.